Jones, and this PALi talk will cover rheumatology and the basics of arthritis. And just to go over what we'll go through defining arthritis quite simply, and then moving on to the key points in examination and history taking when considering a patient with a musculoskeletal presentation, and then go on to discuss both osteoarthritis and rheumatoid arthritis in a little bit more detail. Arthritis is quite simply joint inflammation. There's numerous diseases that have been recognised to cause joint pain and reduce range of movement of joints, and every year around a fifth of the population consults their GP or primary care services with a musculoskeletal problem. So it's a large amount of work for primary care sector, and it's an important thing to know about. Because so many people present, it's important to take a really good history. It's important to ask, is it a single or multiple joint involved? And then what actually does the patient feel? Is it mostly pain, in which case Socrates' history of pain and any history of rest pain or nocturnal pain are really important. And things like swelling, does the patient notice any joint swelling? Which joints, what makes it worse, what makes it better, is it worse at the end of the day, is it worse at the start of the day, and such things. And then finally, another key feature of arthritic presentations is often stiffness, and the pattern of this stiffness, when it occurs during the day and how long it lasts, whether it's morning stiffness and it lasting a couple of hours, whether it's gelling after they've been sat down for half an hour and struggle then to move again, the joints seized or stiffened up, is really important and guides you towards the most likely diagnosis. It's also important because a lot of arthritic conditions are actually systemic conditions, like rheumatoid arthritis. To ask about systemic features, ask patients if they've been experiencing any fever, any weight loss or fatigue, tiredness, muscle wasting, thinking about things like any signs of anemia, anyone notice they've been looking particularly pale recently, any changes to their skin that might suggest a cause, whether that be nodules, maybe psoriasis that might suggest psoriatic arthritis. And a lot of inflammatory arthritises are also associated with eye involvement and things like red eye and sore and acutely painful eyes. It's also important to ask about shortness of breath, as some conditions can affect the lungs as well, as they're systemic. And as with any history, last sort of things also include anyone in the family ever had similar symptoms. Some conditions are hereditary, and it's important to find out. And also it gives you an idea of what people are concerned about, and if grandma so-and-so or aunt so-and-so or mum had this or that, they're obviously going to be concerned if they've had negative experiences of the disease in the past. And finally, social history is really important. Asking where they live, who they live with. Have they got young children? Do they look after their parents? Are they single? Has their housing got stairs in it? How do they cope with them? Also things like their occupation, if they've got joint problems affecting their hands, what are you able to do? What do you do? And how can you get around things, and how can we make life easier and allow you to continue to work? And also things like hobbies. If you can't do what you enjoy doing, it's obviously going to have a negative impact on your psychological well-being. So it's important to find out what people enjoy doing, and wherever possible try and facilitate that in your subsequent management of the condition. For example, a footballer with sore knees will obviously want to get back to playing football or rugby, or other such things such as knitting and sewing are often quite important activities for people. I'm not going to linger long on examination. There's an exceptional book by the Arthritis Research UK charity that's available free for students, well, for anyone online, and there's a link at the end of the presentation to it. As with any regional examination of the musculoskeletal system, it's quite easy, even if you're in a panic. You look, you feel, you move, and then you assess the function of that joint. Always assess the joint above and below to make sure there's not any referred joint pain. But as I said, the book is very, very useful. You can download it, or you can get it sent to you for free by the charity from their website. Now I'm going to move on to look at osteoarthritis to start with. This is an exceptionally common degenerative joint condition that's the most common form of arthritis. As we all get older, there's increased prevalence of osteoarthritis, and in fact 4/5 of us, 80%, have radiological evidence of osteoarthritis when by the time we're 65. But it's important to remember that actually only 30% are symptomatic of this. So despite having radiological evidence, not everyone will need treatment, or in fact will present with it. And osteoarthritis is quite simply the joint failure stage of the repair process of synovial joints. That means we're constantly repairing our joints, where we put wear and tear and strain through them. But eventually this process becomes abnormal and causes symptoms such as extra bone growth and pressure around the joints, and we'll go through that on some of the radiographic changes a little later on. There's quite a few risk factors for osteoarthritis, genetics being one of them, of Caucasian ethnicity is another, female gender, previous trauma to a joint or a bone, particularly any fractures or dislocations can increase the rate of osteoarthritic changes. So obviously you've got increased healing and bone turnover around those when you are actually healing them up, and they may be slightly out of alignment, causing adverse joint loading. And then certain jobs and sports you adversely load the joint anyway and get in unusual and unnormal positions for your joints to be loaded in. So these are all important things to consider in patients presenting with joint pain. Osteoarthritis is primarily classified into two main forms. There's primary osteoarthritis, where there's no obvious insult, so just general wear and tear over the years, and then there's secondary osteoarthritis, where you may have fractured your fibula tib fib when you were younger and caused damage to your ankle joint, and subsequently that speeded up the rate of deterioration and arthritic changes in that joint, and you subsequently develop symptoms and pain from it. I'm going to quickly talk through the sort of characteristic clinical features of osteoarthritis now. One of the main ones is often pain, and as I said earlier, it's important to ask when the patients experience the pain. Pain at rest is common with movement, and at the end of the day after using joints a lot, the pain might be worse. Pain at night is a particularly important symptom. It's often a sign that it's significantly disrupting their life, and a patient might be suitable for joint replacement if that or surgery is appropriate. Stiffness is also common in osteoarthritis. It's normally short duration in the morning, 10-15 minutes. They get better very quickly once they start to move. It's often worse at the end of the day after you've been moving. And there's this phenomenon of gelling, where after say 30 minutes of resting, attempt to get up and stand up and move around again, and the joint becomes stiff, and it might last up to a short amount of time, again 10-15 minutes, before that joint loosens up and they're able to use it as fully as they were. Patients often claim knees or what have you give way underneath them. It's quite a difficult thing to pin down whether they tripped, whether they were loading the joint abnormally or what have you, but it's a common complaint of patients when they present with osteoarthritic joint disease. And joint deformity is another important sign the patient may notice, or you may notice on examination of the joint. There may be an asymmetry between the left joints on the left and right hand side, and often patients or their family will become aware of it and they'll point it out to you and ask you to have a look. And finally, reduced range of movement, particularly in the shoulders and the hips, might lead to difficulty mobilizing. The shoulders, particularly getting dressed and putting on clothes. If you can't lift your shoulder above your head, it's quite difficult to put on certain clothes. Or even in the hands, trying to put buttons on and other such things. So it's really important to ask, not only have they got reduced range of movement and test it, but also say what can't you do or what can you do now. Some very characteristic clinical features of osteoarthritis. In the bottom right pitch here we've got Heberden's nodes of the distal interphalangeal joints and Bouchard's nodes of the proximal interphalangeal joints. But the most commonly involved joints are the knees and the hips. Obviously you take a lot of strain through them and weight, and you load them all the time, so walking upright. Your distal interphalangeals, your carpometacarpals and your wrist, and also your shoulder joints are the most commonly involved. And as I said, your Hebden's nodes are your distal interphalangeal joints. You get sort of bony deformity and overgrowth, and your Bouchard's nodes of your proximal interphalangeal joint. There's 4 main X-ray features associated with osteoarthritis, and these can be best remembered using the LOSS acronym, where there's loss of joint space, osteophyte formation evidenced here on the medial border of the femur and tibia. It's just your spur of bone growing up at the joint margin there. Subarticular sclerosis, which is evident with annotated there, sort of whitening of the joint of the bone, and also subchondral cysts, which aren't evident in this radiograph, but sort of loosened areas below the joint, just below the joint and the bone surface. The mainstay of osteoarthritis management is encouraging exercise and encouraging weight loss. Also suggesting appropriate footwear, making sure people aren't abnormally loading their joints because of the way they are walking, using different footwear and inappropriate footwear, things like heels and other such things that aren't very stable. The use of walking aids if appropriate, sticks or what have you, and encourage, if available, physiotherapy is also recognised to be beneficial. Medical management often involves just simple analgesia, starting off with non-steroidal anti-inflammatories if these are indicated and suitable in a patient, they've got no contraindications, and then just using the World Health Organization pain ladder to achieve adequate analgesia. And if the patients keep moving up, intra-articular steroid injections may give longer term relief for a few months, and if those fail, then surgical assessment and the potentially joint replacement may relieve pain. It must be clear here that surgical intervention is to relieve and minimize pain rather than to restore function generally, although because the patients may have less pain, they may find their function improves. It's not primarily as a rehabilitative option. Going to move on now to discuss rheumatoid arthritis, and this is a slightly different kettle of fish to osteoarthritis in the sense that it's a chronic systemic inflammatory condition. So as well as mainly affecting joints in what's typically a symmetrical deforming peripheral polyarthritis, by that we mean small joints of the hands and feet are often involved first, and then it might become more centralized. It also affects other systems in the body, the lungs, the cardiovascular system as well. So it's a systemic disease. And in fact, it's the most common persisting inflammatory disease worldwide. It occurs in all ethnicities. It's a slight female preponderance, and usually the age of onset is between 20 and 40 years, but that's not to say it's exclusively in this period, and older patients, and in fact some younger patients, may present with this disease. Rheumatoid arthritis is significantly associated with the HLA-DR4 haplotype, with up to 3/4 of Caucasians with the disease having this genetic trait. And in fact it's also associated with a more severe and erosive disease sort of process. Other risk factors for rheumatoid arthritis include cigarette smoking, postpartum and breastfeeding, and the reason for these aren't quite clear. The cigarette smoking promotes inflammatory responses, so that is understandable. The pathophysiology associated with rheumatoid arthritis is synovial membrane infiltration and inflammation due to lymphocytic, macrophagic and plasma cell infiltration of the synovium. And this is just a perpetuating loop where positive feedback just encourages further infiltration, the formation of what is called a pannus, which spreads over the synovial membrane, causing progressive erosion of it. And this causes pain as the joint swells and destruction of the joint, both the synovium and also the bone surfaces. And there's autoantibody produced by plasma cells. And the key driving factor, and this is important now for considering therapies, is that TNF-alpha, tumour necrosis factor alpha, is the pro-inflammatory cytokine that's heavily involved in this inflammatory response and cycle that encourages and perpetuates inflammation of the synovium. When taking a history and examining a patient with rheumatoid arthritis, the general presentation is joint pain and stiffness, particularly in the mornings. It can generally lasting at least half an hour, usually well over an hour. And it just takes a significant amount of time for these patients to be able to actually use their joints at all. There's often joint swelling, and when you feel these joints, they feel boggy and warm because unfortunately I haven't got any actual x-rays of this, but x-ray features of rheumatoid arthritis show the soft tissue swelling. And by that you mean the inflammation also affects the tissues around the joints. They swell up due to edema. There's periarticular osteopenia, so the bones appear more loosen and around the joints affected. And there's erosions actually of the joint surfaces, particularly around the edges, the margins. And these generally result in deformity. There might be subluxation of the joint, there's loss of joint space. And as I said, deformities and subluxation where the joints just do not align correctly are common features. It's a deforming arthritis. When investigating these patients with typical features of arthritis is important, it's important to do blood tests. A full blood count is good for checking if there's any anemia, particularly chronic disease. So that would be a normocytic, normochromic anemia. ESR and CRP are useful markers of active inflammation and let you know the status of disease at that point in time in terms of inflammation. Rheumatoid factors, a commonly cited marker. It's important to test, but you must remember it's fairly non-specific for rheumatoid arthritis. And actually, anticyclic citrullinated peptide is a far more specific and sensitive test for rheumatoid arthritis. Diagnosis of rheumatoid arthritis is actually a clinical diagnosis. There's no set diagnostic criteria. However, having said this, there's criteria used for research purposes, and this has actually become increasingly used in the clinical setting as well. And if a patient demonstrates 4 or more of the following features, it's highly suggestive of rheumatoid arthritis. And these features include morning stiffness for longer than an hour for at least 6 weeks, continuously. More than 3 joint areas involved. Arthritis of the hand joints is particularly synonymous with rheumatoid arthritis, as is symmetrical arthritis, remembering it's a systemic condition. Rheumatoid nodules on the skin, particularly around the elbows, also suggestive. Rheumatoid or anti-CCP positive. And also the radiographic changes we've already been through. So it's not an easy diagnosis, and it's certainly not one that could be made on the spot. It's involving multiple factors to take into account before you can actually label it as rheumatoid arthritis. It's important at this stage just to think about deformities associated with rheumatoid arthritis. It's characteristic and historically remembered as a deforming inflammatory joint disease. But actually, deformity is becoming less common now with the advent of actual effective treatments and immune disease-modifying treatments of rheumatoid arthritis. But characteristic deformities often include the Boutonier's deformity, particularly of the thumb, seen in the right-hand graphic and also the top picture there. Ulnar deviation and subluxation of the metacarpophalangeal joints is quite common. The fingers turn out towards the ulnar side of the wrist due to subluxation of the metacarpophalangeal joints. And also swan necking of the fingers is a common trait. and it's best examined looking at the patient's fingers from the sort of lateral view, and you'll see a characteristic shape with the flexion of the distal interphalangeal joint and hyperextension of the proximal interphalangeal joint. As I said, now for rheumatoid arthritis there are actually effective management methods available, and the way these are all patients with rheumatoid arthritis are all managed is through a multidisciplinary team involving multiple people, as this then allows all aspects of their life, work, social, home, disease, mental and physical well-being to be combined, and everyone is aware of them and works together to ensure and maximise patients' quality of life. Analgesia is obviously important. Relieving pain allows people to actually participate in more things, and is obviously a nice thing to make someone pain-free. And as before, using the World Health Organization's pain ladder and the use of non-steroidal anti-inflammatories is important in rheumatoid arthritis. Steroids can be very useful in the acute phase to provide symptomatic relief, whilst establishing them on what is now known as disease-modifying anti-rheumatic disease drugs. And the aim now is to start all patients with a diagnosis of rheumatoid arthritis on these within 3 months of their onset or diagnosis. And this is because they actually reduce the rate of any of the disease process and provide patients with relief from the symptoms. Generally methotrexate is the first line, but if that patients don't respond to that, you add in subsequently sulfasalazine or 5-hydroxychloroquine. And all of these are disease modifying by acting on different pathways, so folic acid antagonism, 5-aminosalicylic acid, and also reducing the immune response as in hydroxychloroquine. If DMARDs fail, then we also now have these biological therapies which target exact processes in the immune system that are involved in rheumatoid arthritis. So there's the anti-TNF-alpha agents such as infliximab, etanercept, and adalimumab, as well as the anti-B cells like rituximab. And these are actually giving some patients significant relief. A common exam easy question or MCQ question might be asking about complications of DMARDs. And there's a few recognised ones, so for methotrexate, GAI upset, hepatotoxicity and pneumonitis are all things you've got to watch out for. So often patients will have regular chest x-rays to assess for any signs of pneumonitis. Sulfasalazine is recognised to cause rash, hepatitis, and neutropenia and pancytopenia too. And obviously if any patient presents with any signs of infection, you've got to be very careful in these group of patients, as they may have a dampened immune response due to their medications. And finally, hydroxychloroquine, very specifically, all patients on it must have annual ophthalmology appointments, as it has been associated with a reversible retinopathy. However, this is in much larger doses than used in the treatment of rheumatoid arthritis and is very rare. It's still an important and legally required follow-up if patients are on it. So I hope this has been a useful PALi tutorial. As I said, the Arthritis Research UK website has fantastic information, not only on examination, history taken, but also on more specific diseases such as rheumatoid, osteoarthritis, and others like psoriatic. And please do go and read extra if you want to, it's very useful. It's all free and all very simply and well laid out. Thanks a lot for listening.